Hello, welcome. This is the first of our online virtual fellows research talks. I'm very glad to have you joining us today. My name is Phil Pass. I'm the Alumni Relations Manager at the college at the moment, and it's a real pleasure to have you all joining us for this. There are about 250 people registered for this event today from 23 different countries, which is a really great number for us to see, and we're really grateful for the support of all our Trinity community for joining us today and being part of these events. This was just the first of a series. There are a few more scheduled over the next few months, so do look out for details coming of those soon. Firstly, just a little bit of housekeeping. We're relying on technology. This is Zoom, of course, so if something goes wrong, we will do everything to get it working again. It shouldn't go wrong. We hope it doesn't go wrong, but you never know. There is always that slight risk. You won't be seen or heard because this is a webinar style Zoom meeting rather than a meeting. So don't worry about noise at your end or anything like that. The session will be recorded so that we can see it back and watch again and shared with everyone. And there is a chance for everyone to ask questions throughout the talk. There's a little Q&A box at the bottom of the screen. So do type your questions in there any time throughout the talk, and Rebecca will do her talk first, and then we'll come to the Q&A at the end. We're aiming to get everything sort of finished within the hour, but we'll see how everything goes. So over to our first speaker in the series. I'm delighted to welcome Professor Rebecca Fitzgerald. She's a Professor of Cancer Prevention at the University of Cambridge, where she directs a multidisciplinary program for the early detection of cancer. Rebecca also practices medicine as Honorary Consultant in Gastroenterology at Addenbrooke Hospital. She's been a Fellow of Trinity since 2002 and was elected as a Fellow of the Academy of Medical Sciences in 2013. I'm delighted to welcome Rebecca, who will be talking today on a wonderful topic, which is catching cancer early. How long is a piece of string? Rebecca, over to you.
Thank you, Phil, very much for that introduction, and good afternoon, everybody, or good morning, depending where in the world you are. And it's a great pleasure to be giving the first of this webinar series for Trinity. So if I can have my first slide, what I'm going to do is to give you, first of all, a kind of broad overview of the problem of cancer presenting late, give you some idea of the size of that problem, and a broad view, first of all, of how we might tackle that, what our aspirations are in the field. And then I'm going to spend most of the time talking about cancer of the esophagus in particular, which is the cancer that I work on, and the progress we've been making towards an early detection test. So, first of all, is early detection of cancer scientifically plausible? How could it be that we could really start to detect it before it's even apparent? And the rationale for this is that the life history of a cancer is actually a very long one. And for most of the time, the cancer is actually silent as it's starting to develop. So as a cell in a tissue starts to become abnormal with a mutation in its DNA, that cell may then start to expand and to cause a small abnormality or a lesion, which we might call hyperplasia, and it then can become pre-malignant. So if we were able to see it, there is a detectable abnormality, but at that point, the chances are that the individual would be completely unaware of the presence of this dysplasia because it wouldn't be causing any symptoms, and it could be very, very small, micrometers in size, and just sitting on the superficial layers of a tissue. So it's not disrupting the normal functioning or physiology of that tissue. And then gradually that dysplasia may become an in situ cancer and then locally invasive. And it's that locally invasive stage that we really clinically term a cancer. And that's often the point at which a patient will become aware it's there. It may cause a lump, or it may still be maybe internal, but they start to develop some symptoms which would at that point cause them to go to the GP. Now that whole process of becoming precancerous and malignant can actually take many years. It's estimated up to 10 years for most common epithelial cancers for that process to occur. So then that would give rise to the question, given it's such a long natural history, can we detect it earlier before it really starts causing a problem so that we can then intervene effectively and subvert it? It gets more complicated than that because some of these pre-malignant lesions or precancerous lesions actually may not go all the way through to become a cancerous lesion. They may remain rather indolent. And so the other big challenge in the field is to make sure that we don't start looking for things and causing a problem where actually it may never cause harm to an individual. So overdiagnosis and overtreatment is the other side of the coin, if you will, the yin and the yang of this challenge and opportunity that we have. Next slide. So let's think about how much of a difference early diagnosis would make if we really took this as a clinical strategy. These are statistics from Cancer Research UK. It's a summary for 8 different types of cancer combined. And clinically, we tend to group cancers according to their stage. And this is mainly done on imaging to see if there are any involvement of lymph nodes, for example. So if we take it that early stage diagnosis would generally be those cases we call stage 1 and stage 2, versus the late stage, stage 3 and stage 4, then survival overall is 3 times higher when cancer is diagnosed early. And so the government's Life Sciences Industrial Strategy just last year has put out a very ambitious goal of to try and increase the early stage of diagnosis from 50 to 75% by 2028. I think it's hard to kind of get one's head around these statistics. If I can have the next slide, please. And this was a puzzle I actually set for World Cancer Day last year. If any of you follow the puzzle on Radio 4, BBC Radio 4 today, early in the morning. And so the question is, how many cases of cancer would we actually, would this translate into with a new strategy? So if we look at the UK data, there are 363,000 new cases of cancer diagnosed every year in the UK. And 81% of those who were diagnosed early survived their cancer for at least 5 years after diagnosis using those CRUK figures, compared with 26% diagnosed late. So the question I posed on this puzzle for today is, each year, how many more people will survive their cancer more than 5 years if we meet this new government target of increasing from 50 to 75% of cases diagnosed early? Next slide. And here is the answer. So the additional number of people who will be diagnosed, 25% times 363,000 is 90,750. And using that figure, 81% would survive with the new target. If we look at how many more that would be compared to the 26% who would have survived anyway, that's 81% minus 26% times the 90,000 figure. That's 49,913 more patients surviving their cancer for 5 years in the UK, so nearly 50,000. And I think that just gives us an idea of the scale of what we're talking about. Next slide. So there are a number of considerations when we start to think of a test. What would an early detection test look like that could really have an impact and be feasible? And there are a number of aspects to this. There's the technology itself, of course. So, what would that technology be? How accurate is it? And also more on the logistical feasibility side of things. So what would the test entail? How much would it cost? What would the access to that diagnostic look like? Is this something that could be done in the community setting, or will you have to go to the hospital and so on. And these are some of the themes that will come through in my discussion of esophageal cancer, of things that we've really thought carefully about, to think not only about what is theoretically possible, but what is practically achievable in the NHS setting today. Next slide. So there are a number of different approaches one could take to making an early detection test. The first ideal might be to have a pan-cancer test. So this might be a test that you could apply to anybody in the population to ask the question, do they have a cancer somewhere? And ideally that test might also give you a clue as to where that has arisen. And there's a huge interest in this now, particularly using blood. And this has become possible to even contemplate, which really wouldn't have, we wouldn't even have been able to think about this 5 or 10 years ago. But because of our advances in sequencing DNA and the technologies around that, which are becoming increasingly sensitive, it is possible to detect DNA shed from a tumor into the blood, even before you know it's there. This is, as you can imagine, increasingly challenging the earlier you're trying to detect that cancer, so the smaller the lesion. Because obviously if there isn't a molecule of DNA in the aliquot of blood you take, then no matter how sensitive your technology, you won't find it. But this is the concept of blood biopsy, as it's sometimes called, or cell-free tumor DNA. And there are different sort of analytes in the blood that one can assess. And one of the tests out of Hopkins that has really helped sort of pave the way for this sort of technology is called CancerSeq, and that looks for a combination of mutations and proteins secreted into the blood. Next image, please. You can potentially look for early stages of cancer in any fluid, so blood is one. The other idea would be to detect this in the breath, a sort of breathalyzer for early cancer, with the idea that the volatile following metabolism through the liver of cancer cells could be detected as a sort of specific signature on the breath. And you may have heard anecdotal stories of dogs sniffing cancer, and there are remarkable stories of dogs sort of sensing a difference in their owner's breath, and that being a signal that a cancer has developed. So can we then do that in a more systematic way through a breathalyzer, as shown here in this picture, and then using mass spectrometry, for example, to actually biochemically detect the volatile. This picture here is the technology from Alstone, which is a Cambridge spin-out. First, the technology was actually developed for detecting unexploded weapons and missiles and so on, and has now been extrapolated for use in medicine as well. Next slide. So here's something perhaps we're more familiar with, because this is an existing screening test. So this is a stool test for colon cancer. It's a kit that you do at home. And currently most of our screening tests are actually sent out to everybody above a certain age, for example, or it might be men versus women for breast cancer screening, but there's very little in terms of risk prediction to enrich the population to decide who you test for that cancer. So the screening tests that we currently have in the UK are for breast, for colon, for cervix. And they basically start at a given age, and it doesn't really take into account whether you have a family history or whether you are prone, for example, due to your lifestyle factors, smoking, drinking, that sort of thing. And there's a lot of interest at the moment by the National Screening Committee about whether we should be a little bit more targeted in how we apply screening tests. Next image. And so the idea comes about that as more and more we can understand what that personal risk profile might look like, we could then, rather than doing a kind of one-size-fits-all for screening, we could start to be rather more targeted. And there are significant advantages around this, particularly if you want to avoid the overdiagnosis that I mentioned before, and also in terms of the costs of introducing such a screening program. So this is an example of something called QCancer, which is a calculator that a GP can put in the characteristics of the individual and then determine, based on their risks, whether it would be appropriate at that time to offer such a screening test. Next slide. So what I want to move on to now is thinking about esophageal cancer, because this is a cancer that we don't have a current screening test for. And to my mind, it's a cancer that's very suitable to think about an early diagnostic strategy for reasons that I'll explain. So this schematic just shows you the esophagus in the center of the field there, going down towards the stomach. There are different types of disease that occur in the esophagus, two main cancer types, squamous cell carcinoma and adenocarcinoma. And the adenocarcinoma tends to occur towards the lower end of the esophagus at the junction with the stomach. And the main risk factor for this cancer type is reflux of acid and bile that can give heartburn symptoms. Next slide. So you might say, you know, why isn't esophageal cancer readily diagnosed? What do we currently do? Well, currently the gold standard for diagnosing a cancer of the esophagus is endoscopy. And when do we do endoscopy? Well, generally speaking, we'll do endoscopy when a patient has got swallowing difficulties, may have heartburn as well, losing weight, and that would trigger an urgent referral for an endoscopy. If a cancer is diagnosed, then usually by the time the patient's got symptoms, it's one of those more advanced cancers around stage 3 or 4. So the main risk factor is heartburn. And many of you have probably experienced heartburn, incredibly common symptom affecting around 10% of adults at some point in their lives. And the thought of trying to endoscope everybody with heartburn seems a rather unrealistic proposition. So endoscopy is a barrier. So in my thinking about this and trying to develop an early detection strategy, foremost in our minds was how we could get away from endoscopy and do something much more simple, straightforward, cost-effective, that you could do in an office setting at your GP's, for example, or in a pharmacy. Next slide. So, you know, how could we come up with a test that wasn't an endoscopy? Would we need to do an imaging test so you can visualize the esophagus to find the precancer? That would certainly be one option. And people are developing such sort of pill cameras, for example. But in my thinking about this, I felt that really if we could grab some cells from the esophagus without an endoscopy and then rely on pathological and molecular tests, then that would be the way to go, because we could keep the device very simple, but we could use sophistication in our lab analysis to really understand the stage that the cancers are on that process towards in becoming an invasive cancer versus a pre-malignant disease. Next slide. So just to explain to you the technology, so comparing endoscopy with what we have come up with, which is this Cytosponge TFF3 test. So an endoscopy is carried out in a hospital setting. You need to lie down to have an endoscopy. You're generally sedated, or you may have an local anesthetic at the back of the throat. The imaging is fabulous now that we get. So we're able to see with exquisite detail as you go down towards the stomach any precancerous cells, which is called Barrett's esophagus, the pre-malignant condition to cancer of the esophagus. So you can visualize that and then take biopsies, and they're fine, a very small biopsy, which we take through the side channel of the endoscope, as you can see at the bottom of that image. And the test that we've developed, sort of by contrast, is a pill on a string that you give to the patient while they're sitting in an office setting. They don't need any sedation or local anesthetic spray. In fact, you want them to be able to just use their own swallowing mechanism to swallow the capsule which will dissolve, and I'll show you that happening in a moment, to the give this sponge, which the nurse can then pull back and collect cells on its passage back out of the esophagus. Next slide. I thought you'd just be interested to see what endoscopy is like at the moment due to coronavirus. So the restrictions around endoscopy are quite severe, as you can see here, because it's an aerosol generating procedure. The mouth is open throughout the procedure with the mouth guard. You're putting water and air down the endoscope to clear the view. So you swish water down and then suck it out. And you can imagine that that does generate quite a bit of aerosol into the room. And so we're having to do proactive testing for coronavirus prior to the procedure, and or equip the personnel with this personal protective equipment as shown here. Therefore, the number of endoscopies and the throughput have been significantly curtailed. So if I can have the next image. So there's been a lot of interest in the UK in actually accelerating implementation of this Cytosponge test for use in this COVID-19 situation, because the nature of the procedure means that there's much less aerosol generated. There is still a small risk of aerosol just as you withdraw it, but that's just in the last few seconds. And really, it's very much easier in this kind of pandemic situation than endoscopy. So that's something else we can come back to perhaps in the questions. Next slide. So just to give you an idea of actually how this works. So you swallow the capsule, which will go into the top of the stomach, and the warm, moist environment will enable that capsule to dissolve. We allow 5 to 7 minutes to make sure it's fully dissolved and that sponge inside has expanded. And then as the nurse pulls it out, you'll collect some cells from the top of the stomach and then along the whole length of the esophagus. And in this animation, you can kind of see how clumps of cells are picked up and sort of trapped in this mesh, so that you get really quite a rich amount of cell material. On average, about 1 million cells are retrieved by this Cytosponge, which is, as I say, just a 7-minute procedure. Next slide. So just to give you an example show you what the cells look like. So on the left, we have the endoscopic image of the pre-cancerous condition, Barrett's esophagus. That's what the dark red appearance is. And if you take a biopsy of that, then what you find is that the cells have changed to this pre-malignant condition that the pathologist can identify. You can see the type of cell material you collect with the Cytosponge, and the way that we process it, it's almost like a pseudo biopsy, so the pathologist can analyze it. But the cells that we're looking for are a very small proportion of the total cell material grabbed by the Cytosponge. So what we do is to add a biomarker or an indicator to this cell specimen to make it much easier for the pathologist to spot. Next slide. So this is the test that we have developed for diagnosing the pre-cancer called Barrett's esophagus. And it's an antibody to a protein called trephine factor 3. And with this antibody assay, you'll see that the cells stain dark brown. And this basically just makes them very easy to spot. So this big sea of cells here, which are white, that are normal, non-cancerous cells, the cells that suggest that the patient may be at risk of cancer are just highlighted there by this dark brown stain. Next slide. And one can potentially pick this up in an automated way using artificial intelligence assays for a rapid and affordable diagnosis to save the pathologist pouring down the microscope to spot these cells. Next image. So this is a very interesting area, and there's a lot of regulation around using artificial intelligence to completely replace what a pathologist would do, because you need someone accredited to sign out the case. But using artificial intelligence to help triage the cases so that the pathologist can then have their attention immediately focused on the cells of interest and screen out the ones negative from the positive cases and speed up the time of assessment is hugely useful. And so that's how we foresee artificial intelligence being used in the context of this test, is as a triage and to reduce the pathology time. And so you get this sort of digital image with a hotspot analysis which color codes for you the areas of very low risk in blue to areas where the pathologist should have a look that are likely to contain the cells of interest with this red background that I hope you can see on this image. Next slide. So, we've developed this Cytosponge TFF3 test, and of course the next thing you have to do is to show whether it works in clinical trials. So we've done a series of clinical trials, and this was the first one, and the dates on this kind of portray how long this work has taken to go to concept through to proving it in a clinical setting. And this was a paper published in the BMJ in 2010, and this was a trial we did in primary care in East Anglia. So first of all, just ask the very basic question, would this test be acceptable to patients? We also did look at accuracy, but in this trial of 500 patients, the main concern was about feasibility and acceptability. And next image, please. The next trial was published in 2015 in a journal called PLOS Medicine. And in this trial, we took patients who we knew had Barrett's esophagus and compared that with our controls. So they were patients with heartburn who didn't have the condition, to see, really get a better idea of the accuracy of our TFF3 test to distinguish between the disease, the Barrett's esophagus, and the controls. And those trials went very well. Patients did seem to find it quite acceptable. It was quite feasible to do it in primary care. The accuracy data looked very promising. And so we proceeded on to our BEST3 trial, next slide please, which has just been completed and published just last week or the week before. So this was a randomized trial, and randomized evidence is sort of the gold standard for introducing a new diagnostic test. And for this trial, what we did was we took 13,000 patients around the UK in GP surgeries, and we divided them into two groups, half into the standard of care group. And what we meant by standard of care is these are patients requiring medication for heartburn, so they continue to get their medication, and the GP could refer them for an endoscopy if that was felt to be necessary. And the other half were randomized into being offered the Cytosponge. So the other half were all offered the Cytosponge. They still, of course, took their medication. They only then had an endoscopy if we found a positive Cytosponge result. So what did we find? Next slide. The main question we were asking is, do we find more cases of Barrett's esophagus if we offer the Cytosponge compared to usual care? And when you do these sort of trials, I was not privy to the results until all the analysis was completed. And the project manager asked me what I thought I expected to see, what I was hoping for. And I said that if we could detect 3 times as many cases of Barrett's with the Cytosponge compared to usual care, that would, I thought, be a good result. But here is what we actually found. So it was in fact 10 times more cases on the Cytosponge compared to usual care. So the absolute difference in rates was 18.3, and we convert that to a rate ratio. And for statisticians among you, we have to do some accounting for the design, which was a cluster randomized trial. But the bottom line for this is that the Cytosponge could detect 10 times more cases of Barrett's esophagus than usual care. Now, we were mainly looking for Barrett's. We hadn't designed this trial to look for early cancer, but the other question we were very interested in looking at as a secondary analysis was whether we did detect any cancers or precancers, and whether they were earlier stage compared to those diagnosed in usual care. So the next slide, which is a little bit complicated, but just to take you through what we found here, this is looking at different stages of disease, starting with Barrett's at the top, low-grade and high-grade dysplasia, so that's precancerous states, early cancer, which is stage 1, and then later stages 2, 3, and 4. And on the far right-hand side, I've just written down what we do in these scenarios. So if we find Barrett's esophagus, they enter into a monitoring program. If we find dysplasia or early cancer, they're offered treatment down the endoscope or microsurgery. If it's later stage, then we're talking about chemotherapy or surgery, or if it's very late, unfortunately, palliative care. So of the 6,388 cases in usual care in the far column, we found 13 cases of Barrett's by the GP referring for an endoscopy. They found some cancer, 2 cases of cancer, which were treated with chemotherapy and surgery, and 1 unfortunately had already passed away by the 12-month follow-up period within the trial, and 1 patient with advanced disease for palliative care. Next slide. So the rest of the group were offered, the other half of the patients were offered the Cytosponge. Now, they didn't all take up the offer of Cytosponge. About 24% actually took up the offer. So first of all, let's consider those who were offered it but didn't have it. So some of those were detected with Barrett's. There was 1 patient who actually phoned us up interested in the trial, but before they could have the Cytosponge, they went off to have an endoscopy because they had some symptoms, and they had a stage 1 cancer, which was treated by endoscopy. And then there were 2 patients with advanced disease. And then we had the patients who were offered the Cytosponge and actually accepted it. Next slide. And here we see this large number of patients we diagnosed with Barrett's esophagus and some early cases of cancer. And to me, this is really a really important finding of this trial, that we could detect cancers earlier than we could in the other groups. And these patients all went on to have what's pretty straightforward treatment actually when you catch it early. So microsurgery down the endoscope, some we call it radiofrequency ablation, using heat energy to burn away the superficial layers. And these patients with an outpatient-based treatment could be cured of their disease. Next slide. And this is 1 patient who had an early cancer detected, who has been very keen to tell her story, which has been very helpful to us. So she's a retired scientist in Cambridge who was really curious about this technology, and so she took part in the trial. She had a positive result. You can see there the positive staining from her Cytosponge. Next image, please. And when we had a look down the endoscope, she had Barrett's esophagus with a nasty big ulcer that turned out to be cancerous. This was shown on an ultrasound test. This is using an ultrasound probe down the esophagus to be early stage. Next slide. She had microsurgery down the endoscope to remove the areas. Next picture. And the pathology of the area removed showed that it was a very superficial cancer, and she was very fortunate because it was just at the point where it was starting to go deep. Next slide. And here is Liz, if we just start the video, that patient who...
Called the Cytosponge. You swallow the device and it helps to find something called Barrett's esophagus, which is a condition that can potentially develop into cancer. Liz is one of those lives it saved. She had no idea she was ill, but volunteered to try the device out of scientific curiosity.
I was just interested in the trial. I'd never heard of Barrett's esophagus, which is what this is looking for. And so I thought, yeah, I'd be interested in taking part. And I was very lucky, because if I hadn't, I wouldn't be sitting here now feeling perfectly healthy.
The idea is simple enough. Once in your stomach, the casing dissolves, leaving this wiry-looking sponge behind. After 7.5 minutes, the nurse pulls it back out, and it scrapes millions of cells from the lining of your esophagus or food pipe.
So I just wanted to show you that because you get a sense of the whole procedure, but also I hope you noticed she was actually speaking to the cameraman while she had the string still down. So it's really quite well tolerated, and yeah, Liz has been a real advocate for this technology. Next slide. So I think the treatment is obviously very important for any early diagnostic test. You have to think, you know, if you find something, what are you going to do about it. And for esophageal cancer, it's very stark, the difference. So if we detect cancer when it's superficial, then we can treat it with endoscopic therapy as an outpatient day case with excellent survival figures. If it's more advanced, we're talking about chemotherapy and surgery, quite arduous treatment with a poor 5-year survival, less than 20%. And for our patients who are palliative, then it's symptom control, often doing something like putting in a stent to help them eat, but with very poor outcomes. So really, this is an example of a cancer where you completely transform the quality of life and what the patient has to go through, as well as their survival by early diagnosis. Next slide. So as I mentioned at the beginning, we have to think about the access to diagnostics as well as what the technology involves. You could just flick the other images onto the slide, please. And one thing we've thought about is you know, for the Cytosponge, where it's best given, you can't really give it yourself at home. You do need something to do it for you, but GP surgeries are very busy, keep coping with the demands of, you know, symptomatic disease. And I think we need to think hard in our health services about how we unburden GPs with screening type procedures, and whether we could do it, for example, in the pharmacy. I just put these images up here for other sorts of technologies and the way people are thinking about it, where you might do self-testing or even have sensor technology which would alert you that you could be developing a cancer without you even have to go to the doctor. There are pros and cons to all these approaches. Be happy to discuss that with you, but I'm not sure how we'd all feel about the kind of big brother approach to our health, whether we want to be monitored all the time, but on the other hand, if you wait for symptoms, whether it's too late. So it's finding that sweet spot about what's really feasible, affordable, socially acceptable, and the ethics around it too, that are all important aspects of early detection. So it's not just about, you know, how far you can push the technology, but what's appropriate for society and what the sequelae of that would be. Next slide. So just to finish up, we're now thinking about, on the back of the results of this clinical trial, how we can talk to NICE and clinical commissioning about where we would position Cytosponge technology in the clinical pathway. So in the primary care setting, we are keen on identifying patients on long-term medication for heartburn, often proton pump inhibitors or PPIs, and offering them a Cytosponge in what would be a nurse or pharmacy-led clinic, and only endoscoping those who have a positive test, and being able to reassure the majority of them and even reduce the medication requirements, because a lot of these patients just get put on these medications for life. In the secondary care setting, if I have the next bit of the slide, we're also thinking about patients referred in by their GP to hospital for endoscopy, whether a number of those would be suitable, particularly if they've got heartburn symptoms, for a triage with a Cytosponge to relieve some of the burden on endoscopy. And this might be especially relevant in our current COVID-19 situation, where there's a big bottleneck for endoscopy services. Next slide. Yeah, so it's just to say that this is aligned with commissioning priorities, and we have to think about the economics, of course, at all in this. And we know that increasingly our more precise drugs that target the molecular aspects of cancer are very expensive. So there's a question about, you know, whether precision cancer medicine is going to be affordable for the NHS, and if we start really moving more towards early detection, is that going to add more costs, or is it going to be cost saving? And the economics are quite complex around this. Of course, it will cost money to do a screening program, but then if we could diagnose cancer at an early stage, then we potentially reduce the costs of cancer treatment, and of course improve longevity, and the economics of that also then can be very favorable. So there are some estimates on the amount of the savings to the NHS from early diagnosis. This is CRUK statistics from a report in 2014. But I have to say the data really around these models are somewhat crude, and I think there's a lot more work to be done on really properly working through the early detection economics. Next slide. So I want to ensure that we've got time for questions, so I think I've really covered what I wanted to say. But just to mention that my thoughts in developing this particular technology, the Cytosponge, have been very much around what's practically feasible, and trying to be rather low-tech in terms of the device, but to couple it with lab tests, which I haven't talked in a lot of detail, but as well as the TFF3, we can add on other more molecular tests to really identify the people at higher versus low risk. And as from a global point of view, this sort of technology is very applicable in low resource settings as well, which is also something we're very interested in. Next slide. So thank you very much for listening. I'll be very happy to answer any questions. How long is a piece of string? I can tell you that this particular piece of string on Cytosponge is around 55 centimeters. Thank you very much.
Thank you very much indeed, Rebecca. If we were in the Winstanley like we normally would be for something like this, I'm sure there'd be a very large round of applause now. So thank you for that, and thank you very much. There's been lots of positive comments coming in on the questions, which has been good to see. What I might do is just go to a couple of the early ones that came in, and then we'll move on to the ones that are much more related to the Cytosponge, because there's quite a few that have come in clustered around that. But there were a couple of questions about early detection and DNA and that the role that might have earlier on. So Ray Schoenfeld said, a remark that's been attributed to Jim Watson, that the discovery of DNA would lead to a cure for cancer within 100 years of that discovery. Since 2053 is well within the career horizon of young researchers today, how does that group judge the chances now?
Yeah, so I mean, there's no doubt that DNA has completely revolutionized our understanding of cancer, both relevant for diagnosis and for treatment. And of course, one of the things we've become very well aware of is that cancer is not a single disease. And we can cure some cancers now that would have been unthinkable earlier. But we know now that we're not looking for, you know, a cure for all, or we are looking for a cure for all cancer, but it's not a matter of finding a single cure that's going to do the whole lot. So to answer your question succinctly, I think, yeah, the insights that we've had through understanding the mutations that occur in cancer are absolutely phenomenal, that are enabling us, many of the technologies I've mentioned to you, the blood testing, the sorts of things we can do on devices which sample cancer specifically, like Cytosponge, do absolutely rely on looking for those mutations, understanding which the more prevalent ones are, and then our targeted treatments, many of those are targeting specific mutations in pathways that cause the cell to go awry. So I think a lot of progress has already been made thanks to that discovery, and there's still a lot more to do.
Okay. Peter Tompkins says that he understands that some general population screening, e.g. for breast cancer, if done too early in life, can lead to unnecessary treatment of people who may never have gone on to suffer it. And you sort of did touch upon that side of things, at the higher cost and damage to the patients treated than the resulting cancer. How do we educate the public into not clamouring for too early an intervention in screening? And of course, that could go for other types of cancer as well. That could include things like prostate cancer in men, and it comes back to the economics question that I think also I saw Paul Sever said about, you know, if the people have acid reflux, could we afford to use the Cytosponge in these cases? So anything you'd like to sort of say on those ones?
Yeah, I mean, I think this is a really important point. And I'm very glad you brought it up. So overdiagnosis and overtreatment is going to be a problem the earlier you detect things and the more sensitive your technologies. And I suppose one question is, you know, is it about educating the public into not clamoring for these interventions, or is it about doing more research and clinical trials to really understand how we better enrich the population for a given screening technology, and making sure that those technologies are fit for purpose and as accurate as possible. And I guess it's going to be both. But I think even though there are downsides, to really improve outcomes for cancer, I'm talking, you know, inevitably generally here, and this is particularly true for some cancers, you know, it really transforms the outcome and the sort of treatment you have to require, and therefore the side effects and comorbidity of those treatments if you can detect it early. So I think there's definitely a place, you know, I don't think we should give up on detecting cancer early, but on the other hand, it needs to be done well, and it needs to be done precisely, and it isn't a matter of screening everybody for everything, in my view. So I think we need smarter early detection. I mean, in terms of whether you can afford it for the Cytosponge, I think was the second part of your question, for everybody with reflux. Again, it would come down to the cost of the technology. Cytosponge has been licensed to Medtronic. They haven't fixed their costs yet, and it's also the sort of thing, the more you know, once you start doing it at scale, the costs would come down. And the costs also depend on what you do next. So if you can give everybody with heartburn the Cytosponge, if you then had to endoscope everybody who was positive, that would start being more expensive. But if, on the other hand, as well as your TFF3, we can add other tests, which is what we're researching, to really identify the high risk from the low risk. And if the ones that are very low risk, even if they've got a TFF3 positive Cytosponge, you can still just follow them up potentially with more Cytosponges. You don't have to put them into endoscopy. Then it can get more affordable. So it's all about really using the technology well and thinking what the sequelae are to keep the cost of those down.
That sounds a very important point, though, being able to reuse this test or to use it again with a different, and it's quite a good way of making sure that you're using medical supplies sensibly rather than the time that it would take to undergo endoscopy or any of those other things. So excellent. Terry Stancliffe says an interesting breadth of diagnostic possibilities is under discussion here. But what about assessing the rates of false positives and false negatives? Or if such measures are not available and not obtainable, what other methods can be planned for assessing the performance of the diagnostics under discussion here? I think you spoke a little bit about that in some of your slides slightly later on.
Yes, I mean, I didn't go through all the details of the trials, but I mean, it's absolutely imperative to properly assess the rates of false positives and false negatives, and also to ensure that you assess that in the relevant population. So a lot of these sort of studies are often done in rather small cohorts, so small numbers of individuals. And often the place to start, which is completely understandable and appropriate, is to take people with the disease and compare it to people without, in often a small sample size. And then it looks quite good, and that's published, and that's great. But then if you really take it to the broader population that you would actually ultimately want to deploy this in, where the amount of disease in that population is a lot lower, then of course you will find that the performance of your test is not the same, and the rates of false positives will go up. It's very important to test in large scale studies in the relevant population to get good data on accuracy, and that's, you know, what we have really tried consciously to do in our BEST 2 and BEST 3 trials, and then to think about how you can really reduce your false positive or false negative rates. Maybe you can tweak your the thing you're measuring, for example, the threshold of that test, and again about enriching the population up front, so you're only testing those you need to test. But very important question.
There's one that's just come in sort of potentially on the back of that from Christopher Green that says, are the algorithms used to analyse patients' words describing their symptoms uniform across the various types of cancer? And, you know, such as sudden changes of body weight. I don't know if you can see that one just come in at the very bottom.
I understand that question quite. Are the algorithms used to analyse patients' words describing? Yes. So actually this can be a real challenge for GPs, because often, and we all know what it's like trying to describe symptoms, our symptoms can feel rather vague. It's quite difficult to put a word on it. And certainly, you know, for esophagus, heartburn, indigestion, reflux, these are all terms which are used rather loosely, sometimes interchangeably, and can be difficult to interpret. And then when you're recruiting for patients for trials or deciding which test to give them, you might have to really drill down on what those symptoms mean and what test is appropriate. So actually it is an area of some confusion, I would say. Probably hard to uniform these terminologies entirely. Clearly we try to when we're doing a trial, but even then it can be somewhat challenging.
There's quite a few comments coming in, lots of people saying thank you so much for this and what a great talk. So thank you for people to telling us that, and obviously to Rebecca for taking part and for doing this for us. There's a few questions coming in about the Cytosponge itself. So I think maybe let's do a couple of those. There's some people asking about taking part in the trials or volunteering to take part. Is there anything that you can say to that?
Thank you. So yeah, I'm just looking as well at a number of these questions about Cytosponge. So someone said, you know, how uncomfortable is it? Does it cause discomfort? Could you get bleeding? So it's really remarkably well tolerated. And I don't know if you noticed the patient on that video, she was talking while the string was there. You saw it being pulled out. So it's going to make your eyes water for that last few seconds, but it's actually pretty straightforward compared to endoscopy. And on the scale that we ask people to rate it from 0 to 10, where 0 is absolutely horrible and 10 is very nice. Actually, the median was 9 in our trial. It could potentially cause bleeding, but we ask patients to stop if they're on anticoagulants, and it's really, bleeding has not been a problem at all. We do have FDA, Medtronic have FDA approval for this product. That's something someone asked, and it's CE marked now. And the next, in terms of ongoing research, the next work we're doing is this is a grant funded by Innovate UK, and the idea is to, Innovate UK is keen to see how we accelerate adoption of research into clinical practice. And so the aim of our Innovate UK study is really all about some of those rather boring but very important things about how you introduce a new technology into the clinical service, where it fits in the clinical pathway, how long the appointment takes, how you do the training, how you get the sample from A to B, all those sorts of things. So that's the study that we're now doing. The project is called Delta, the research project, and we are recruiting to that project. And so if you are interested in volunteering, I'm sure we'd be delighted to tell you more about that.
And how would they do it? Should they get in touch with us and we can pass them on to you?
That would be great, or ping me a message directly. Yeah.
If you are interested in taking part in future trials on this, if you drop an email to alumni@trin.cam.ac.uk and mark it from this talk, and we'll make sure that gets to Rebecca. There's a question that says, could something like the Cytosponge be used to diagnose prostate cancer or other types of cancer like that, or is it very specifically for the swallowing?
Yeah, I mean, Cytosponge is quite specific, but the concept can absolutely be broadened. So I think there are two general sort of approaches to detecting cancer early. One is this kind of pan-cancer test, so using the blood or the breath, you know, to see is there a cancer anywhere. And the other is to go more to the target organ or tissue and see if you can collect something, image it or collect cells to look for a specific cancer. And there's a lot of interest in that for a broad range of cancers, and particularly for organs which are quite accessible. So the esophagus is one of those, but the lungs, the bronchus particularly, bladder, cervix, obviously there's already a program, but could you improve on that? So organs which are accessible, and the sort of analogous approach to Cytosponge would be using some kind of swab or brushing and then coupling that with laboratory tests.
Great. And Rob Cuthbert says, has the Cytosponge programme started to change our understanding of the prevalence of Barrett's in the general population?
Yeah, that's a good question. Yeah, absolutely, because we've had very little data on that before, actually. The prevalence in the BEST3 trial was 8%. And those were patients on medication for heartburn. So we had already, you know, done some targeting of who we thought the relevant population would be. And it's a male predominant disease, which we did already know, but that was also borne out by this general population study.
And that's another question that was in there asking, had sex aggregated data been used to talk about that as well? So great. Probably just time for maybe one or two more questions. Is there anything that you'd seen in the questions box? There's loads still coming in. Is there anything that you
well, someone who had a family member who died of esophageal cancer, and just to express my sympathies for that, and just, you know, to say how much I know this can be very devastating disease for those affected, and thank you for listening. Someone has said the Cytosponge has been around for about 10 years. How long is it before it's going to become available? And you know, it has taken a long time to develop what, to all intents and purposes, is a very simple kind of test, which, you know, is frustrating, but on the other hand, there are a lot of aspects to it. I can say that the first clinically commissioned case was done by UCLH yesterday. As I said, we're still doing that Innovate UK study, but actually yesterday was the first case which was actually UCLH have decided to commission a service because of the COVID restrictions and because of the strength of the trial data that's just been published. So that's very exciting. So I think it really will be available really very soon now. Quite how widespread that uptake will be, I don't know yet, but I think that's you know, very promising. Question here about whether Barrett's identified on screening is the same identified in symptomatic people. That's really interesting. And one of the interesting question, and one of the things that we've been thinking a lot about, because actually of COVID-19, is, you know, if you've got all the trial data from one sort of case scenario, which is in our case in primary care, if you then move that slightly and say we're going to do it in secondary care, people with symptoms because of COVID, how applicable is that evidence? And you know, you have to be a little bit careful because the prevalence of the disease in that population will be different. The test characteristics, it may perform slightly differently. You know, we know that in secondary care, the risk of you actually having a cancer is going to be higher than if we're going in a screening population. And of course, we want to make sure we don't get it wrong. So there we're doing some slightly different sorts of tests, as well as the TFF3 I described today, to try and make sure that in the secondary care setting, we really don't miss anything. So the interesting thing with this kind of test is that you can change the lab tests to suit the particular question or population you're interested in.
There's a couple of questions in from Ehab Maka. We'll maybe just pick the sort of the first one, which is, it jumps back a little bit back towards the screening question, and people could be screened for lots of different things regarding precancerous lesions. Do you wish to venture a personal opinion on favour or not of screening people in general for lesions wherever in the body they occur? Or
yeah, I mean, I guess this is a personal view, you know, I lead an early detection programme in Cambridge, you know, that's investigating all sorts of early detection tests. But I've also been very insistent that as part of this programme, we include experts from social sciences to really think about the broader ramifications of this, because actually I think it is not altogether straightforward. And I am not actually personally in favour of testing everybody for everything, because I think the danger is, and this of course may change and evolve as the technology improves, but where we are at the moment with the technology, I fear that will overwhelm us with you know, finding a lot of things that probably are not going to be harmful for the individual and causing a lot of anxiety. So where we are at the moment with many of these technologies, I would be more for trying to identify the individuals at risk of particular cancers who have got most to gain from detecting it early, in whom we can absolutely really improve their quality of life and quantity of life in a way that's really worthwhile, but not going out for finding every little tiny mole or pimple and getting ourselves worried about it, because I'm a great believer in living life to the full and enjoying it while we can.
That's an excellent way in which to sort of bring this to a close. So thank you very much. And I'll just take Sanjeev Pandya's comment, which says, it just simply says, what an excellent idea. Technology simple and effective. And I think that is what this whole Cytosponge project and the research associated with it clearly shows, that sometimes the ideas that so you sort of go, well, why didn't everyone think of that, is there. So thank you very much, Rebecca. This is, as I say, this has been your sort of second time of doing something for us in the last couple of years. So that's been great to see. And we really appreciate having you as part of this and with us. I need to say thank you to the team at Trinity as well, to Matt Feast, Rachel Sweet, and to Mike Gormer for helping put this together so we can actually have these events. And thank you to everyone who's joined us today. It's been great to see so many people and so many questions. There are more events coming up. Our next one is on the 8th of September, and it's going to be featuring Professor Greg Hannon, who's also in the medical sphere, and he's going to be doing a talk on lessons from studies of tumour heterogeneity. I should have practiced that before it came up. So yeah, that's the 8th of September. You can go to our website now to book for that. We will send around a video of this recording in the coming days. And thank you very much. Hope to see you again soon.